Hi all. My name is Sian Gadamu and I work for the Aspen Global Innovators Group. Thank you for joining today's live Aspen Health for All conversation. These conversations are part of a larger effort housed at the aspenhealthforall.org that is amplifying the important work being done by leaders and innovators all over the world to address the disparities that have been amplified by COVID-19. Our aim is to focus on health equity and connect a range of experts working on the front lines of health around the world as we all pivot to respond to the challenges of COVID-19. We are in search of common solutions and shared insights. As the US reckons with the legacy of racial injustice and the continued systematic oppression of Black lives, we want to take this moment to say that we will not tolerate violence and hatred against Black communities. Our global community stands tall with local leaders, collaborators, healers, and fellows who've long been beacons in this moment and whose voices and work are critical to reshaping a healthy and equitable future for all. Today, the Aspen Global Innovators Group is excited to host a conversation with Dr. Kirsten Bibbins-Domingo, Vice Dean for Population Health and Health Equity in the UCSF School of Medicine. She co-founded the UCSF Center for Vulnerable Populations at Zuckerberg San Francisco General Hospital. And Dr. Sam Hawgood, renowned researcher, professor at academic leader and pediatrician and chancellor of UCSF. They'll be talking about how one of the nation's largest health systems is taking discrete steps to support some of the country's most overlooked communities and setting an example for cities and health systems across the country. Now I'll pass it over to our moderator, Peggy Clark, Executive Director of Aspen Global Innovators Group.
We're so delighted that you could join us today. Let me make sure that I'm great. Welcome, everyone. I'm delighted to welcome you to our talk today. This is a fascinating conversation with two leaders who are really at the forefront of the question of how do we address COVID with particular attention to vulnerable populations. UCSF, University of California, San Francisco, has really been at the forefront of the COVID pandemic, not only in San Francisco, but also the state of California, the nation, and the world. And I'm delighted to have the opportunity to talk with two leaders, Dr. Kirsten Bibbins-Domingo. Welcome, Kirsten. Delighted to have you with us. Hi, Kirsten. There you are.
Thank you very much.
I know how busy you are. Thank you for joining us all today to tell us a little bit about what's behind the scenes. Sion gave a great introduction for you, but I do want to say that, well, congratulations on being the inaugural Dean of Population and Health Equity at University of California, San Francisco. And we are fascinated by learning more and peeking behind the curtain what you and Sam have been working on. And then let me please welcome Dr. Sam Hawgood. Sam, are you with us? There you are.
Good morning, Peggy. It's a pleasure to be here.
Good morning, Sam. Lovely to have you with us today. Thank you so much. And Sion again introduced you, but I do want to say that in the conversations I've had leading up to this event, I am really struck by how much we can learn from Sam and Kirsten about the way that UCSF has been building partnerships and collaborating behind the scenes in the COVID response, unlike maybe many other institutions across the nation. So let's just jump into our conversation. Let me tell all of our viewers and listeners that we would love to have your questions. And so you can go ahead and put your questions in the Q&A box. And we will be saving time at the end of the conversation to make sure we get to some of them. So let's all go back in time. It feels like a million years ago, but it was actually only about 4 months. And so it's February 2nd. And Sam, you told me it was 2 a.m. when you admitted the first 2 COVID patients to the newly established Emergency Response Center at UCSF. What were you thinking at that moment? What were you imagining was ahead? And what were some of the first steps that you took?
Well, thank you, Peggy. At UCSF, we have a large Institute for Global Health Science and many faculty who spend their life studying pandemics and the epidemiology of emerging pathogens. So when the UCSF community first started to hear of the reports coming out of Wuhan, China in late December, and then through the month of January, we could fairly reliably predict, based on prior history of novel viruses and how quickly they can spread, particularly respiratory viruses, that we were concerned enough that we were likely to see activity, particularly on the West Coast, because of the frequent travel back and forth with China. So we established, it was actually Super Bowl Sunday that we established our emergency command center before there was really any activity in the US, but we wanted to get ahead of the curve. And somewhat to our surprise, or I would say a great deal to our surprise, within a few hours, we were asked to admit from the South Bay two patients, a husband and wife, who fortunately had very mild illness, but because we knew so little at the time, we admitted them to hospital. And it was a great learning experience for us in terms of knowing what was coming. We honestly thought we were going to face a major surge, but it started a number of conversations that moved extremely quickly with the departments of public health in the Bay Area. And we are blessed in having very strong public health in the Bay Area. And I think we're also blessed by the fact that our elected officials allowed public health to take the lead here. And the elected officials and politicians played a support role. And that was really critical in letting the science and the data drive the response. And we've seen the benefits of that over the last 3 months.
Mm-hmm. So fascinating. So Kirsten, let's turn to you. Where were you on February 2nd? And what were some of the first things you were thinking?
So I don't remember the exact date, but I do remember very much the feeling at that time. I am a professor at UCSF, but my clinical practice is at Zuckerberg San Francisco General Hospital, and that's the city's safety net setting. And I think the things, as Sam said, we all started to prepare. We were preparing for the surge that we anticipated happening. Our hospital, it really works out of the Department of Public Health. And I think what I remember most about those early times is how much collaboration started very early. So Sam talked about how fortunate we are in our city because of the leadership, because of the Department of Public Health being very forward thinking. But also I think early on there was established a very strong sense of collaboration across the hospitals, of thinking not just what UCSF was going to do, but how the city as a whole could be prepared for a surge. And I think that spirit of collaboration is how we've met the public health challenges throughout each phase of this pandemic.
Right. That's so helpful. So let's fast forward just a few weeks. And, I think San Francisco had the eyes of the world when Mayor London Breed declared a state of emergency and issued a shelter-in-place order, really among the first to begin March 17th. And as I understand it, around this time, you converted a major research lab into a COVID testing center. You mobilized over 100 graduate students, and you were actively working with departments of public health. So how did that partnership evolve with the city of San Francisco and the state during this time? And how do you think those early steps helped to bend the curve? Let me start with you, Kirsten, and then go to Sam.
Sure. I think the collaboration that started early were really critical. And it's not just that we came together, but we were willing to meet the pandemic with all of the tools that the university has at its disposal. And you're describing the phenomenal testing that has happened, that we really created capacity for at UCSF. Also, the basic scientists were working from the very first moment they had information from what was happening in China to start helping us to understand really the basic biology of this virus. On the clinical center, the clinical front lines, I can say from my vantage point at Zuckerberg San Francisco General, we knew the patients we were starting to see at ZSFG, turns out most of them, if not all of them, were Latinos. They were young men in their 30s and 40s, almost all Latin. And even though the city has a large Latin population, it's only about 15%. And so all of a sudden seeing only Latin patients in our safety net hospital made us concerned that we were seeing a trend early on. And I think that defined much of how we responded clinically, and also define some of the early ways in which we approached our scientific response.
Yeah, thanks. Sam, let me turn to you. How, at the time that the mayor declared the early shelter in place, it seemed like a pretty radical step. Tell me a little bit about how you were involved in those conversations and whether you think that was a particularly important both partnership and decision.
Yeah, for me, you know, I go back almost 40 years to the HIV epidemic and what became a pandemic, where it really was the epicenter in San Francisco, and the entire city, but the university played a major role in thinking broadly that we needed to have a complete community approach here. Yes, there needed to be fundamental basic science because we didn't even know it was a virus at the time. But we had to transform the way we cared patients, and we did that in very, very tight collaboration with the city. And many of the leaders who cut their teeth in the early and mid 80s dealing with HIV/AIDS are now the leaders in the departments of public health in the city and in the Bay Area. And I think that stood us incredibly well during this time because we'd done it before. We knew we could do it. It didn't really matter what it was. We were just ready. And so when the Grant Colfax, who's the director of public health in San Francisco, and worked very closely with his fellow directors in the 9 Bay Area counties, came together as a collective decision, not to just shut down one county, but to do it together, because we realized this was a regional issue, that people moving back and forth across the region. And then for the politicians, the mayors and the county supervisors to have the courage, truly, where before there was even a single death, at least what we thought at the time, there hadn't been a single death, to effectively shut down was a courageous move. And we had lots of back and forth conversations as a major healthcare delivery component of the city, and stood totally behind those decisions. There was no wavering. And I think it's hugely credit to the population of the Bay Area that they followed in line. There were a couple of little pockets of unhappiness, but for the most part, there was tremendous support and community compliance in what was only in retrospect seen to be a hugely successful move that has probably literally saved tens of thousands of lives. There's been some calculations, and it's probably in the 30 to 40,000 lives saved by those decisions. So it was an honor to be part of the team and to stand beside the mayor and the Department of Public Health. And for me, one of the things that I've taken away from this is the absolutely critical role that academic health centers linked to major universities play in public health crises. You know, historically, we're sort of known as the place of last resort for exotic, complicated, serious disease like neurosurgery, complicated cancer. But I think this is really underscored, much as like the HIV/AIDS crisis indicated, that when there is a community-wide public health crisis, the role that academic health centers can play by bringing all of their assets to bear, their research, their care, their public service, and particularly a public university. And I hope we don't lose that, because you know, healthcare in the United States is terribly fragmented. And I think, I hope we can learn from this pandemic across the country and better prepare ourselves for the next one, because there unquestionably will be another one.
Yeah. And Sam, the results have been pretty profound, right? The actual number of deaths in San Francisco relative to other cities. What are the numbers there?
Yeah, so San Francisco is a relatively small city, rounded up to 1 million people, but we've had 44 deaths over the last 4 months, which is remarkable, to be honest, truly remarkable. Truly remarkable. We've admitted patients at UCSF. I think we've admitted nearly 130 patients, many of them critically ill, and a similar number at Zuckerberg San Francisco General, where we provide, where the university provides all of the physician care. But we've had remarkable results, I think in part because the particular severe component of COVID-19 is a respiratory problem called acute respiratory distress syndrome. And it happens to be a clinical area that we have been very interested in and involved in research for 20 or 30 years. So we have great teams, but I think our results are less about UCSF and more about the public health decisions, because it allowed us to provide maximum care to every single patient. We weren't swamped. Our resources were never overwhelmed, be they nursing, physician, or personal protective equipment, et cetera. And our results pan out. Over the 140 patients we've treated at UCSF, many in critical care, we've only had 6 deaths. And some of those were admissions direct to palliative care because of age and other factors. So I'm proud of what we've done, but in part it's because of the quality of care we could provide, but overwhelmingly it's because the public health decisions prevented the health system being overwhelmed.
Right. That's really fascinating, Sam. And I do want to say, I think both your and Kirsten's leadership in just jumping in and being courageous distinguishes so much of what you've been able to achieve. So let's continue on our timeline. So let's go forward a little bit to May. And I think it was in May when you began doing some of the most interesting community testing in the Mission District, in little tiny Bolinas, California, very diverse places. And now, of course, in Bayview, particularly in areas where you saw a lot of cases and high levels of challenges given the low income nature of those communities. So let's look at a few images. And Kirsten, maybe you can tell us what we're looking at here about this community testing.
Sure. So our testing actually started in the end of April and at our first site in the Mission. And that was really driven by the observation of many of the clinicians at Zuckerberg San Francisco General that we were seeing a disproportionate burden of disease in our Latino populations. So that was in the Mission. We tested over 4,000 individuals in one particular census tract in the Mission. As Sam said, the question is, what do we do as a university? We lead with providing data, we lead with providing education, and we lead with providing clinical care. And this is really at the heart of what we were trying to do here. What you see here is like an extraordinary number of community volunteers. This is actually the Bayview site. So you'll see an extraordinary number of community volunteers. They helped us to get the word out to the community so that they would know that this was available, that they could come for testing. And that was important also for helping to reduce stigma in these communities. As we realized it was affecting some communities more than others, we really didn't want to have this be a stigmatizing issue about getting tested and finding this out. We also had tremendous volunteers amongst our students and our faculty and other of our healthcare providers who, particularly in the Mission, really provided the testing. What you're seeing here is the person who's doing the testing has to obviously be fully gowned and gloved and everything because of the nature of the types of testing. What you're watching here is that we were testing for both PCR, that's the actual presence of the virus for people who are acutely infected, and also for antibody testing so that we could understand how who might have been exposed in the past and could understand a little bit more in these communities that were most affected, what might have been the patterns of transmission in those communities.
Mm-hmm. That's great. Thank you.
One of the things I want to just say, and you can see here us going to a person here. This is the study that we've done in unhoused populations this past weekend. And I don't believe this person themselves is unhoused, but I want to just make the point that we also were very interested in taking testing to the people who needed testing. Again, our job as a university is not to replace the Department of Public Health or be the source of all testing, but to really focus on those areas of greatest need and to lead in a way that we can provide information to the departments of public health to figure out how to launch a more specific public health response in the communities that have been disproportionately affected.
That's great, Kirsten, and thank you for sharing those images with us. So, there's a lot of talk about how COVID is hitting Black and Brown communities much harder than other places. We talk about health disparities, but it's hard for a generalist or others to really understand what that means. And what is the how behind that? How then does one address the nature of the fact that we are seeing these huge disparities in results? And let me go to you, Kirsten, and then let me turn to you, Sam, because I think that there's a kind of an explicit focus that UCSF has and a way of working with communities that perhaps others can learn a lot from. Kirsten, can you share with us how you can tackle this?
Yeah, I'll just tell you what's been now really the hallmark of how we've done now 3 different large-scale community testing projects is really to partner first with the community. And sometimes that is easy to say. What does that mean to partner? This is more than just, oh, we needed communities to help us distribute flyers. This was community members saying, you should be in this part of the city and not in this part of the city. That nobody goes to that particular field, they will go to these other fields. And what it's meant by partnering with community leaders who can be on the ground and give us the on the ground knowledge is that they were leading and we were following. We were supporting essentially an effort that they very much were front and center in leading. It's also meant that we were very keyed into the types of responses. So when people test positive for COVID-19, we ask them to isolate. We ask others who might be exposed to quarantine. And those are really hard. They actually require resources to do that. All of us, we would have food delivered, but if you're in a lower income part of town, you can't have food delivered. This might be an issue of you not working, might create challenges financially for the family. So the community-based organizations, those community organizations that always provide support in these communities are the ones that we enlisted their help in bringing food to people who might have tested positive, in following up with symptom checkers, in helping to think through how to connect them to clinical care. And so the community response has been not only the way that community leads, but also is the way we have invested, in fact, in some of those communities. And we think these durable partnerships are what we hope allow us to continue to go back over time as we continue to support these communities through every phase of the pandemic.
Right. I think that's such an interesting point about investment. Sam, what are your thoughts on this? What's your...
Peggy, I think it's important to recognize that while COVID-19 may have brought this issue into the public eye in a shocking way, the issue of health disparities and health inequities has been with us for centuries. And it's an area where there's been very little progress made. And well before COVID-19 was even a word, at UCSF, we, like all major institutions, go through strategic planning, and we identified health disparities and health inequities as one of the 3 legs on our strategic plan, and really identified it and tried to call it out as the challenge of our generation. Again, I reference back to HIV/AIDS because I arrived in San Francisco in 1982, just as the epidemic was exploding. And I think for all of us, Kirsten included, who trained during that particular decade, that experience has influenced how we think about medicine, how we think about our responsibilities in the community tremendously. And we've tried, and the fact that Kirsten is our very first dean of health disparities, I think reflects the fact that we believe it really is the grand challenge of our time, and COVID-19 has just brought it. If you didn't believe it before, you believe it now. And I think, in San Francisco, there's probably 20 different zip codes. And if you look across the zip codes, there's a 10-fold or more incidence of this disease for the kind of reasons that Kirsten just described. And if we take a one-size-fits-all approach to this, whether it's testing, other interventions in the community, we're just going to miss the boat. And UCSF was a leader in the movement of so-called precision medicine, and this is an ideal opportunity to take those concepts, which were largely based in things like cancer, where your cancer is different to my cancer, but to take those approaches and put them in the public health domain and say, we know that this disease is not affecting everyone equally, and we have to focus what are always going to be limited resources in those communities where we can have the biggest impact. And that's the wonderful work that Kirsten and her team are doing. Not just the testing, but all the follow-up that's required and the support services and everything else that goes into it.
I just want to say, if you don't mind, I remember when we presented the results of the mission study to Sam, and I wish we could present the results to your listeners, because
I'd like to offer a follow-up conversation, but just give people a teaser about this really quite path-breaking study.
Sure. I think when you see next, I believe we're going to release this next week, you'll see the full on, and it's a wonderful study when I think about, because it represents the best of the collaboration internally at UCSF. It is our basic scientists who came together to do the testing, who made it really possible, and who really have been just as excited as everyone else to do this. Our clinical and epidemiology colleagues who really have designed and figured out how to do this. And again, that's the internal collaboration. The external is all with our community partners. But I remember when we presented the results to Sam, and Diane Havlier is the scientific lead of this study. She presented this results to Sam. And what we saw, and this has already been reported in the media, so I can tell you this part, is that when we tested in this area of town that has both Latin American populations, Latinx populations, as well as white populations, the positive results were really predominantly, almost exclusively in the Latinx populations. And this was a little bit surprising to us. And it really spoke to the workers, the people that people our low-wage workers are part of our essential workforce, and they were on the front lines. They were delivering food, keeping our streets clean, doing all of those things that we needed for this public health response, and that put them at risk.
Right, fascinating.
And so that was it.
That's fantastic. And I do want to promise our listeners to do a follow-on about the study, because if you've said it touches on some of the scientific issues, what we know about asystematic and other factors, as well as community ones. But I want to make sure we go to some of the questions, since we don't have too much time together today. And this is kind of a hard one, but I'm going to go ahead and ask it. What are some of the major and hard to resolve impediments that you face in bending the COVID-19 curve and equalizing inequities? And I understand there's a report that you wrote, which is what's beneath the bend in the curve, and then also how can this not happen again? Let me just jump to Sam for a minute, and then Kirsten, you can jump in. What do you think are really the hardest to resolve issues as it relates to this question?
They get back to the socioeconomic inequalities in our communities, really across the country, but including in a wealthy city like San Francisco, where the burden of disease is really concentrated on a very small proportion of the community. They are ethnically linked, as Kirsten has said, but really we have to put the resources into those pockets of the community. Otherwise, that will be a continuing seed of new disease that will cross over and potentially become a surge before there's herd immunity or a vaccine. And that means tremendous political will to put resources into those communities that, as Kirsten said, are essential workers, but are not recognized as essential workers like nurses, doctors, et cetera, who are being honored across the country for very, very good reasons. But it's really a mind shift that's needed.
Yeah, I'll say the same thing. It is a mind shift, because it's each of us are not safe until all of us are safe. And this is a mind shift that says, even though many areas of town are doing well, some are not. And if we're all going to be safe in a pandemic, we actually have to not feel comfortable that our community, my part of town, is fine, but really understand what do we need to do to get those communities that are also going to face the economic crisis even more, with more challenges now, to be safe during this pandemic.
Right. I have some fascinating questions coming in. I think we're going to have to do a follow-on to this, but one thing, just quickly, is people have asked about housing and security, how this is affecting it. Secondly, how this COVID has forced various organizations to work together in ways that are responsive, rapid, and more efficient. How can these partnerships be institutionalized more moving forward? And then I have a third question about whether community workers were compensated in contact tracing. So Sam or Kirsten, anyone want to jump in on any of those three?
Yeah, so I have a huge interest and focus on making sure these partnerships are sustained beyond the immediate crisis. In fact, one of the legacies of my chancellorship that I hope will come about is what I call transformational partnerships, because I believe the really big challenges, including health disparities, cannot be solved by any single institution alone, whether it's a political institution or a great university. We have to reach out and do partnerships, and we're making a lot of progress in the Bay Area. In terms of compensation, I have to give a big shout out to the Chan Zuckerberg Initiative and the Chan Zuckerberg BioHub, who provided not only the testing for the projects that Kirsten has mentioned for free with volunteers in the field, but have provided free testing to every single Department of Public Health in the state of California through the lab that UCSF stood up. So a huge shout out to those and many other donors and philanthropists who have seen what needs to be done and have stepped up.
Right, that's fascinating.
I hope we can sustain this, yes.
Yeah, so we're at time, although we have so many wonderful questions coming in. And I really just want to take the liberty of asking the last question. If we go forward 4 months, just very briefly, what do you see and what is giving you some sense of positive hope as we're going forward? Kirsten, first to you and then Sam.
Well, I have to say the energy that I see with people coming together within UCSF, which we have a long tradition of collaboration, but with our external partnerships and with DPH, the amount that's happening without talking about who's getting paid for what, but just how can we get this done?
Yeah.
That's happening even after we finish these massively exhausting testing events. When I call them the next week, they say, yeah, let's do it again. Let's go do it here because there's greater need here. So that gives me optimism that spirit of both innovation, how can we think differently, optimism and collaboration, that will sustain us, and we can try to build the framework around it so it sustains over time. So I'm
that's great. Sam, any last words about what you see ahead?
Very briefly, we haven't had a chance this morning to talk at all about the phenomenal research that is going on for a cure or for a vaccine, and for even more revolutionary kinds of tests. And all of that is phenomenal, both at UCSF and around the world. And that gives me great optimism. My concern is that there'll be community fatigue around public health discipline. We've been very disciplined in the Bay Areas, but as you look across the country, that discipline is not necessarily spread evenly. And I think even in the Bay Area, if there is a recurrence in the fall, which there almost certainly will be because we won't have wiped the virus out by that time, I hope the community can remain disciplined and continue to follow the science and the public health.
Yeah. And Sam, I want to promise you, I'd love to do another conversation around the remarkable collaboration and research you've been doing, and also the results of the study. But I want to just take a moment, one, not only to thank all these fabulous people that are asking such great questions. We could do this as a whole graduate seminar, which would be great. But I want to take a moment to thank the incredible Diane Morris, who's a dear friend. She sits on the board of University of California, San Francisco, as well as the Aspen Institute. And Diane is the one who helped us to think through focusing on this. So thank you, Diane. And I also want to, everyone thinks these Zoom calls are so informal, but there's a whole team behind us. So I really want to just take a second to thank Sion and Katie and all the whole AV team at Aspen for putting this together. And to all of you listeners, I know it's hard to do these Zoom talks, but we are learning so much. These issues are so critical. And we thank you for staying with us. And I think we promise that this particular issue, we'd love to do some follow-on conversations. With each of these Aspen Health for All conversations, we encourage you to take action. These are not just policy talks. These are meant to mobilize all of you to not only take some of these learnings in your own community, but also to support some of the really powerful community organizations that are in place in San Francisco. We're about to put a screen up that will show you some of the organizations if you'd like to make a donation or get involved or learn more. And then we will also have further links in our newsletter, which will be coming out to all of you. But let me thank everyone for joining us. Thank you, Sam and Kirsten. You guys keep up the great work. You're a model for so many. We have so much to learn from you. And thank you so much for joining us today.